everybody.
We are live now.
All right, terrific. So we are live. This is Senate Health and Welfare Committee meeting
Oh, I don't have the Zoom.
on
Okay.
January 13th. And we will, we're going to begin our meeting. Nolan Langwell of Joint Fiscal is here to continue discussion on the healthcare industry. Industry
Overview.
overview.
Health system overview.
Sadly, it isn't.
Yeah, hopefully, yeah.
You'll have to give me a moment, so, because I don't have,
That's okay.
I wait for the Zoom.
I just sent it over for
Yeah,
you.
yeah. And it takes forever for it to get from there to here.
And just FYI, after that, we're going to hear from the Department of Vermont Health Access, which is overall responsible for Medicaid, and we'll hear from them, and then we'll have a committee discussion. Maybe we'll finally get back to two things, to the bills that we passed last year, and then maybe at some point, we want to come back to a discussion about our priorities. And as we start to see bills come up on the wall, we'll reestablish those priorities based on what we've got. So
And I'll let it be in the chamber today.
11. So we'll try and finish a little bit early. How are you doing, Nolan?
I'm doing great. How are you doing?
There you are.
There we are.
Okay.
So we picked
And we now have your PowerPoint from yesterday.
yeah,
Does it include this as well
this is the same
Yeah,
PowerPoint.
we
We
have
just, we just picked the nice spot to
on
stop.
our webpage? I didn't scroll through it yet.
We actually got through quite a bit yesterday, so
Good.
depending on how, I think that there should be plenty of time for questions if we get there. Or we can run down other rabbit holes. For the record, Nolan Langwell, the Joint Fiscal Office. Just picking up where we did yesterday, we were at actually a good transition piece. And we were just about to move into Medicaid. We had talked about insurance coverage, uninsured, private insurance, and we were moving into public. And this is where I was going to talk a little bit about Medicare and Medicaid, and started off by explaining the difference between Medicare and Medicaid. And they're very easily conflated because they're both public government-run health coverages. And they sound very similar. Medicare and Medicaid, people conflate them all the time, including yours truly. I think it was Representative Goldman had a nice little, what do you call that, memory trick. Anyway, her memory trick was, yeah, Medicare ends in an E. E is for elderly. I thought that was a nice little.
Medicare and
Mnemonic device.
Yeah, mnemonic. That's exactly.
That's why he's my vice chair.
Oh, there we did.
I'm so tired lately that I'm forgetting names and words and
You're not alone.
It's complicated. You know that, right?
just like that bumper sticker. I think we might have to use that one for other issues in the session as well. But not to digress, so Medicaid is a state and federal program, whereas Medicare is just a federal program. I think, well, I didn't have it in this slide, but I have it in another presentation where I have a nice big chart telling you the difference of, showing you the chart of all the different coverages and then what you in this room actually have some kind of influence over. Actually, you know what? I want to show that really quick.
Okay.
Let me stop my share for a second.
Great.
I should have put it in this presentation.
State.
Let me pull this slide up.
Boy, we did go through a lot, didn't we?
Yeah, we really did.
Yeah, I mean, we're probably gonna have to circle back on some of this.
Happy to do it.
Yeah, I guess while you're looking there, I'd make a suggestion, if you have time between now and next, not next week, we've got, I think we're a pretty full schedule, but if you have a section of the PowerPoint and the information that no one's presented and would like to go back, let me know and we can do that. Because the redundancy helps in this case. Good. Go ahead.
Thank you, Chair. Can I also just say thank you to Alex for getting all of this to us in a very timely fashion. I really appreciate it, sending us the links and the PDFs.
Of course,
It's really
yeah.
helpful.
If you ever notice that there's not something up there that should be, shoot me a message.
Yeah, no,
because,
it's-
you know,
it's great.
it'll happen, but
Thank you.
happy to help.
I'm not seeing it. Oh,
Best committee assistant.
you know what? Maybe it wasn't this presentation.
The assistant in Ed is a high school student. It's incredible. I mean, you're incredible.
Oh, no,
He's incredible.
Hayden's great, yeah,
Hey,
Hayden, yeah.
wow.
No,
I mean, I was a high school teacher for a long time and he is on the ball.
okay, this is the slide I wanted to show you. So I did actually, it wasn't in the presentation, I was wrong.
It was.
So we're gonna go backwards for a moment.
Yeah, that's fine.
And so we talk about the various pieces for which, you know, we have some state regulatory authority and or financial influence over, you know, Medicaid, and then that small segment of the insurance market, individual, small, group, large group. We don't have control over Medicare. So again, I think to drive home my point, you know, we don't have any influence over Medicare. We have influence about Medicaid. That's actually really, I think this is, if we're going backwards, I do like this slide because it gives context over like what it is this committee has some jurisdiction over and what it does not have jurisdiction over.
Is the title of this one correct still, the private commercial?
No, I didn't change it.
Okay, all right, I just want to make sure
It's on
that's
my
the
list.
one that was, should have, okay. that
Oh,
needs
yeah,
to be
it's
changed.
on my list of things to do. Yes, thanks for the reminder of my flaws. Appreciate that.
We all make mistakes,
Mhm.
it's okay.
Just not on Orca. So again, Medicaid is a state and federal program. We have some control over. Medicare is a pure federal program. Medicaid's for low income. It's for it's children and adults, those 65 or older that are blind or disabled. Federal, it's all incomes, 65 or older. It's also any age if you have end-stage renal disease or if you have certain disabilities. So those are some of the other, I don't want to use the word carve out, but other ways for folks to get into Medicare other than just aging into it. But again, we don't have any jurisdiction over that. Sure.
I'm not 65 yet, so I'm not really, I haven't experienced Medicare, let me put it that way. Is Medicare a program that can be combined with private insurance as well? So can people have both?
Yeah, I'm not the expert on that. I'm seeing everyone
Yes.
shaking their heads.
Yeah.
Supplemental.
You can have supplemental, okay.
So whatever Medicare doesn't cover, so if you have Part A and Part B, and if something isn't covered there and you want to have long-term care, there's a supplemental for that. Then there's also Medicare Part D, which is prescription drug coverage. And if you don't enroll in that the first time you go into Medicare, you pay a penalty if you enroll in it later. So Part D is it's all about, I won't go into detail, but it's prescription drug coverage. So, but, and then the supplemental coverage is for a number of the things that you feel you need: eyes, ears, dental, other things that are specific to you and your healthcare. So the answer is yes.
Thank you.
So as you saw in the previous chart, it's about 21% of the population. That's roughly 120 to 130 Vermonters. You know, we talked about different people there, and most of those, 87% of folks are over 65. This is Vermont, plus 1,500 of the 1,500 kids under the age 17 in Medicare because of various disabilities and others. Again, also anyone with end-stage renal disease. And then some parts, you know, this is Part A, this is Part D, Part B, Part C, and Part D. Some have some additional requirements. And so Part A, as Senator mentioned, is primarily hospital and patient care. Part B is most other health services. Part C are Medicare Advantage or plans options that usually that are approved by Medicare and offered by private insurance company. And I don't want to go down that rabbit hole of Part C. And then we have Part D, pharmacy coverage. Medicaid. So this is really where there's more pieces. This is an area for which you're going to be hearing from. After me, you're going to be hearing from the Commissioner of the Department of Vermont Health Access. We call it the Medicaid Commissioner. The Department of Vermont Health Access is Medicaid. And so you're going to be hearing from the Commissioner right after me. So come in real brief, talk a little bit about who they are, what the department does. And then not too long after that, you'll start hearing about budget adjustment. And, Medicaid is one of the jurisdictions of this committee. And so I know this committee takes an interest in seeing Medicaid budget. And then, of course, Governor is going to be doing his government proposal next week. And then the Medicaid budget will roll out a few weeks after that. And again, this committee will have some jurisdiction over influencing those sections of the budget. Medicaid was created in 1965. It's a public health benefit program for low-income individuals and families and individuals with disabilities. As I mentioned, it's financed through a federal-state partnership, but it's administered by states. I'm going to get into a bit more detail about what that federal-state partnership means. And each state operates and designs its own program within broad federal guidelines. This is a joke, I call it a joke, but that I've been kind of saying in all the committees. And basically, if you've seen one Medicaid program, then you've seen one Medicaid program. And the more we talk about global commitment, which we're going to do next week, and give you a little bit more of the weeds about the confines and the construct of our program, this joke will become funnier and funny, or more and more meaningful, because you're like, wow, it really is a very unique Medicaid program, because we do have a very unique Medicaid program. I think I to quote Ashley Berliner, who I did the presentation with, we're like, I think one of the only Medicaid programs in the country that do our full program through what's called a waiver, and we'll get into details of that next week. But that's a little juicy for the nerds.
If you hear 1115 waiver,
Yeah, we'll get into that next week about what those are, what that means. This space, I put this in here. This is just like I get a Blue Cross Blue Shield card. If you're on Medicaid, you get a card that says Green Mountain Care. So if you hear the term Green Mountain Care, that's the umbrella name for our Medicaid program. Not to be confused for folks. I think only Senator Lyons is here, but back when Act 48 passed, going on, 10 years plus ago, when Governor Shumlin was doing these repairs, it was called Green Mountain Care. And so I think as we get farther and farther away from it, I think I have to make this case less and less, because there's fewer and fewer people who are worth here or remember that. But at some point, I'll be able to take this slide out. The Green Mountain Care refers to, it's like the umbrella name for our Medicaid program. Nationwide, we have 90 million individuals who are covered by Medicaid or CHIP. CHIP stands for the Children's Health Insurance Program. It's actually separate from Medicaid in general at the federal level, but we administer it through our Medicaid program. So when you hear the term Dr. Dinosaur is an umbrella term we use for our kids' Medicaid program, and the kids who are on the Children's Health Insurance Program are covered under that Dr. Dinosaur umbrella. So we administer it through Medicaid. So we count it in Vermont as Medicaid. It's 4,700 kids that are on that program, and they get a different match rate, which I'll get into in a future slide. So approximately 208,000 Vermonters receive some form of assistance through Medicaid. I think at some point, this is a number that I think you'll find useful when you have a constituent or folks say, how many people are on Medicaid? You're like, 208. But there's a caveat. Sorry, go ahead.
No, go ahead with your caveat.
The caveat is we have 1/3 of Vermonters who have some form of assistance in Medicaid. So what I mean by that is when I had my pie chart up before and I said 24% of Vermonters are on Medicaid, that's primary. So we have 163 Vermonters that have Medicaid as their primary source of coverage. Then we have another 45,000 folks that have partial or supplemental assistance. So for instance, our premium assistance programs, folks on the Vermont Health Connect, they have a Blue Cross Blue Shield plan that they bought as on the exchange for Vermont Health Connect, but they may have assistance, some kind of premium assistance that helps reduce their premiums. That's subsidized through the Medicaid program, we get matched. So those folks are not on Medicaid, but Medicaid pays for those things. So we have 208,000 people that have a relationship with Medicaid. But when you talk about on Medicaid, only a quarter of folks are on Medicaid. Whereas, 1/3 of Vermont's folks have relationship with Medicaid. Were you gonna say something, Senator?
No, that's good. I was just gonna say, what effect did COVID have on Medicaid coverage? And have we seen, is this a question for Ashley?
Well, I mean, I can talk a little bit about it.
Yeah, okay.
The answer is, actually, I'm gonna defer this question
Oh,
to when I get
right.
to FMAP,
Yeah, no, that's fine.
because this is part of the FMAP conversation,
Okay.
because we're gonna start talking redetermination. So I'm gonna put a pin in that question, and I'm gonna refer back to it in a few
Not a
seconds.
problem.
So when we think about, Medicaid is, well, when we think about Medicaid, there's two pieces. There's who is covered and what is covered, right? So who is covered, in order to qualify, you have to be a Vermont resident, you have to be a US citizen or permanent resident, or non-citizen with lawful presence. If they have a financial situation that would be categorized as low income or very low income, and be one of the following: be pregnant, responsible for a child 18 years or younger, blind, have a disability, or a family caretaker of somebody with a disability, or you're 65 age and older. And what is covered, we have what we call as mandatory benefits, and we have our optional benefits. So for instance, on the left side, Medicaid, we are required to cover inpatient, outpatient, rural health clinics, home health, physician services, et cetera. These are what we call categories of service. On the other side, these are things that by federal law in our Medicaid program, we can cover, but we don't have to. If we choose to cover it, we'll get Medicaid match, but we don't have to. And those would be, eyeglasses, Cairo, and hospice. What this list is on the right is these are the optional services that we do cover currently. So this gives you a sense of the types of services that Medicaid covers.
So just for clarity, the optional services, they're optional, but the state has absorbed the obligation to the plan.
Yes.
Is that correct?
Yes. So in previous years past, when we weren't under any kind of federal requirements to not change services, people had come to me and said, I want to save some money in the Medicaid budget. What can I cut and what can't I cut? And the answer is the optional services were not required. The mandatory services we are now. We have other legal obligations that we cannot actually reduce those services at this time. But that was a way. But the flip side is that most of the money is in the mandatory services.
Can you say most, can you quantify that? Like 20% is an optional, or just to give a sense of it?
I would say more than half, if not most. I can't tell you off the top of my head, but the biggest costs are inpatient, outpatient, physician services. Those are usually the top three, and those account for a big chunk of our health services. Whereas Cairo isn't going to be a big part of, over a big cost. Hospice is a big cost, but not one that everybody uses. So I don't know off the top of my head, I could find out if you really wanted to know. It's going to be, that's a number that's actually in our Medicaid budget book. So I could find that for you pretty easily. I can actually get you a list if you're really interested.
So will we get that either?
You will when the budget comes out.
Yeah, go ahead.
Very good.
But if that's a document you want, I could make a copy and get it to you. Or
I'm just interested in just a notional percentage.
I don't know off the top of my head. If you want to, I can find out. Doug can find out, or
I would be interested.
Okay.
Just for background.
make a little note to myself.
Yeah, and some of the optional services that are up there have been individual bills that we've passed
Right.
through here. And depending on what the needs have been.
That's easy for me to find.
Do you think DEVA would have that on the tip of their tongue? when they come in?
No,
Yeah, I do too.
but I could get it to you by the end of the day.
Yeah. Thank you.
So just as really more of a brief introduction to the global commitment again. So what we talk about, global commitment to health is the full name of it. And it's the name of the agreement between the state and the Center for Medicare and Medicaid Services, CMS, that is used to administer the majority of our Medicaid program. It's what's known as a Section 1115 waiver, a demonstration project. We often refer to them as waiver. And that term comes from that under that section of the Social Security Act, Section 1115, states have the ability to waive, or the agreement, federal government has certain abilities to waive certain provisions of Medicaid law. See, I did right there. And give states flexibility that encourage state innovation in designing state Medicaid programs. So in short, essentially what it's doing is, states have Medicaid programs. You have your populations you have to cover, your basic. The idea behind a Medicaid waiver is saying, well, we think at the state there are pieces of the Medicaid program that we can do a little bit more efficiently. And as a result, we want to cover more people or do this or do that. We're the only state that actually does our whole Medicaid program as one giant waiver. These agreements have to be budget neutral with the federal government. So you can't be like, sure, you can do this and it's going to cost more. The federal government's like, sure, we'll come to an agreement. We're going to have all these confines and terms and conditions for how you administer it. And it can't cost more than what it would have cost in the absence of a waiver. Generally, these waivers reflect a state's priorities and goals, and they're driven by what's the needs of that particular state's population, what are the priorities of the leaders, those kind of things. At least 40 states had at least one approved and/or pending waiver, at least in 2020. That number may have gone up or may have gone down. The vast majority of our $1.9 billion program is administered through this global equipment program. I don't think I have it somewhere else, but I have the actual numbers of how much is in and how much is out of it. Global commitment has enabled Vermont to implement many programs that would not have received federal dollars in the absence of a waiver. And we're going to get into more details and reads about this next week. This is actually a very interesting subject. I've done this presentation twice that gets into the global commitment in the weeds of Medicaid finance. We did it yesterday, and I'm going to bring in a woman named Ashley Berliner, who is the person at the HC Human Services that was one of the leads in negotiating the waiver. And she knows the weeds of this and a good resource for you to ask specific questions when we get there. This is really just more of like a teaser.
So, and just one other comment about all the Medicaid stuff. And when you look at the provisions for benefits that are there, and for the eligibility, there are rules that are written about those things that come from the administration. So when the global commitment was passed, and when we pass anything about an optional benefit, then the agency of human services through DEVA will write rules about all of that. So income levels and medical condition. So the rules that come back to us can be fairly substantial. So just so
The global commitment agreement is 268 pages.
Yeah.
So it gets into the weeds of various pieces,
Yeah.
what is the eligibility, each of those categories, and it's very specific and very in depth.
Yeah.
But we're going to get into the depths of that next week. This is really just to give you a taste. And also because you're going to hear from the Medicaid commissioner, and she may say things about global commitment or about Medicaid spending, but that's all within global commitment. We have this is just throwing a quick note about term that you also are gonna hear. It's called dual eligibility. These are folks that are eligible for both Medicare and Medicaid. In those instances, Medicare is the payer of first resort. Medicare is the payer of first resort. Medicaid is usually the payer of last resort. So in the that previous slide where I said 21% of folks from Medicare, that would include the dual eligibles. They would be in that piece of the pie. There's approximately 18,000 folks. However, the state spends over $240 million a year for healthcare and other support services for these folks. So when you hear the term, I don't know what the exact stats are, but a large percentage is spent on a very small percentage of people. This is one of those groups that's because they're older folks and they tend to have more, and they're low income too, so they tend to have more chronic conditions. And so there's been a lot of efforts in the works through the years to try to help those folks stay healthy, to help control those costs, managing their diseases, managing their diabetes, et cetera, to try to help keep those folks healthier and out of the hospitals or out of expensive services and having a better quality life. So when you hear the term dual eligible, it's folks that are on Medicare and Medicaid.
And they could be older, but they could be younger and disabled, so it's just, it's a big mix.
Now we're going to get into some more of the expenditures and the numbers. Vermont spent $6.37 billion spent on healthcare in the state of Vermont in 2020.
Combination private, public.
All of it, everything. This is based on the document known as the expenditure analysis, which is a lovely document, and I should send it to you. One more thing to send to you. I like it. It's put up by the Green Mountain Care Board. There's a 2-year lag on it, so these numbers are 2 years old. The federal government puts out numbers too. They call it the national health expenditures, and this is like the equivalent of the national health expenditure, but it's at the state level. And the national health expenditure often does state level stuff, but Vermont's such a small population that their numbers are usually a little off. There's a higher margin of error. This is way better because it's much more specific. So it's also the first year, and you'll see in a future slide, that Vermont actually spent less than the prior year. And that's the pandemic effect, basically. In 2019, Vermont spent $6.5 billion. As far as I've looked back, we've never had a year where we spend less than the previous year. And again, that's just the pandemic effect. I'm sure that when we get to 21 and 22 data, we're going to see that spike back up. So we talked about how Medicaid is about 24% of the population, but Medicaid accounts for 27% of health care spending in Vermont. So 24%, 27% spending. So this has state budget implications.
This is an interesting conversation to think about, and that is when we think about Medicaid folks, they are the lower level, income level, so lower socioeconomic. We look at the total poverty level, they're at that low end.
Yep.
And the relationship between health and income then becomes a topic of discussion.
Yep.
We don't get into that particular discussion, but it is a driving force. So improving people's socioeconomic status may well be a way to improve health outcomes. And then prevention is key, because when we look at social determinants of health, all of those things sort of start to fall into place. Not one thing or the other, it's everything together, unfortunately. Or fortunately, but we can see it. Yeah.
So Medicaid is 27% of the spending in the state, and then has state budget implications. This slide is actually one I stole from another presentation done by someone else at JFO, but I just wanted to give you context of Medicaid's impact on the state budget. So Medicaid is the second largest thing we spend money on after education. Education is the biggest expenditure. Medicaid is the second biggest. And so the blue is the state dollar spend, the orange is the federal dollars. If you put the blue on top of the orange, that would be the total spend. Yes.
Thank you. Sorry, a couple questions. When you say education, are you talking about the ed fund?
Yes, spending by the state, ed fund, any spending on education by the state. That's in the budget.
Right. And my second question is, Medicaid accounts for 27% of the budget, even though it's 24% of the,
27% of total spending in the state of Vermont.
27% of total spending in the state of Vermont, even though it's 24% of the population.
Yes.
Are there any groups that carve out a percentage of spending that it's actually less than the number of folks? I'm just trying to get
Sorry, say that again.
I'm trying to get a correlation between the number of people and the percentage of spending. So are there any groups that account for example, commercial insurance, 32% of the
Oh,
total
yeah.
spending?
You can look at the expenditure analysis and it has the percentage of spending by payer, by type of service, and you can make those. I'll send this document. It's a good document. It's long, but there's a lot of, every page is like a juicy morsel. from that
Right, I
page.
bet,
This
yeah.
would be great to have up under the reports.
Sure, yeah, I'll
reports and
send it
documents.
along.
Yeah,
I'll send it to Alex, but I'll send it to everybody else. I'll send it to
Yeah.
Alex to send out actually.
yeah,
But there's a chart in the back of it that has like the spending as a percentage of, and you can even look at each one and you can see.
Great.
But this Medicaid spending also, to be a little clear, it's a little nuanced, like that 24% was the primary, so that's 163,000 folks. But the spending would also include the other 45,000 because it's Medicaid spending, even though it's on behalf of folks on private insurance. So there is a little bit of noise in that number. But I was just sort of pointing out the state budget impact. And so education spending in our budget is the biggest piece, following Medicaid. But if you look at the chart, you can see that while Medicaid is the second largest expenditure of our state dollars, we get a lot of federal dollars for that program. So it's the highest federal piece.
Mhm.
So, but my point there is it's a 1.9, almost $2 billion budget. And so that's a big deal. Our total budget was 6 billion, somewhere in that. So anyway. So again, Medicaid is about 1.9 billion. It's funded through a combination of both state and federal matching dollars. Roughly 70% of our overall Medicaid spending are federal dollars, which is actually up from previous years for various reasons. Most of that spending is through or matching dollars, which you're going to hear this term called FMAP. You're going to hear a lot about FMAP. FMAP stands for Federal Medical Assistance Percentage. Basically, what FMAP is the methodology is determined by the federal government. It's the share of state and Medicaid costs covered by the federal government. The federal government calculates it based on a 3-year average of state per capita personal income compared to other states. And no state can receive less than 50% or more than 83%. So for instance, states like New Hampshire and Connecticut and Massachusetts, they're at 50%. They're never going to have to pay more than 50%. But then you look at Mississippi, they're almost at 80%. They're at 77.27. Vermont, for fiscal year 24, we're at 56.75, which means that for every, and I'll go back, for every dollar we spend, we get $1.30 match, and which translates to $2.30 gross. Or another way of looking at it is for every dollar we spend, 43.48 is state, and 56.52 cents are federal. So for every dollar we spend, we get $2.30 in services. Now, one of the things that I point out when we've had years in the budget where we've had deficits and there's been looking to cut services and programs, the point we have to make is for every dollar we cut, we lose $2.30 in services. So the majority of our program is under this regular FMAP rate. Now, we also have some other populations for which we receive what are known as enhanced FMAPs. So for instance, our children's health insurance program, which I mentioned earlier, is 4,700 kids under that program. That match rate is roughly 70-30. So for every dollar we spend, we get $3.29 in services for those children, for that population. And then we have this group called childless new adult. Don't get confused by the name, but essentially this is the expansion population of the Affordable Care Act. And this is the population of folks that didn't fall under the traditional Medicaid that were falling through the gaps when they were trying to create the Affordable Care Act. So this is a population of adults who are childless and are below a certain income threshold. Typically, it's 138% of federal poverty. This is about 47,000 folks currently. But what happened was, and we get a 90-10 match for these particular folks.
47,000 in Vermont.
And
And then really, having this up here is very instructive, you know, because we have 138% of poverty, one person household. The income level for determination is $18,754. So that's to cover everything.
Why is it significant that they're designated as childless?
because of and Ashley did a nice job explaining this the other day, but
Oh, sorry.
we have, no, not here, in another
Oh,
committee. So I'm gonna try to
Well, we
Channel
create
her.
that, right, yeah.
I'm gonna try to channel, but basically Medicaid, if you look at the eligibility, you know, it's pregnant or you're responsible for a child, so that's someone who has kids, or you're blind, or you're disabled. And so essentially the childless, if you were a low income folks, but didn't need any of these people,
Oh, I see.
you were falling through the gap. And so this was trying to scoop those people up as well, the low income folks that fit the income category, but none of these others. Prior to the Affordable Care Act, a lot of these folks were covered under a program called BAP, and some of them were covered under our Catamount Health program, but those had to go away. But anyway, this is to cover that population, so that's why they're childless. And you know, we don't have a good reason for why we call them new adult. I think it's just they were new at the time. We have these things called Medicaid eligibility groups. So in the front end, you just see you have coverage, you're Medicaid, but on the back administrative end, people are put into these different buckets based on their eligibility. And we get different matching rates depending on what bucket you fall into. And this was a new group. And so these were the 9 to 10 folks. So it's really a back end term, but it's sort of stuck. Because I had a lot of questions about why are we calling them new? Are they new to the Vermont? It's the back end. It was new when we created it.
Yeah,
Anyway, it's just stuck. It's an administrative term per se.
just a thought, if we going back to the other slide where
Yeah.
there's a list of the states and how much match they get from the federal government.
Yeah.
I always like to look at the sort of the health outcomes for some of these states. Vermont is pretty much at the top, and we were really rated very well for health outcomes. But then you look at a state like Mississippi, and Louisiana's similar, and their health outcomes are very poor.
Well, there's also a relationship to the per capita income.
Yes,
Right? The relative economics of the state, and there
Yeah.
tends to be a relationship between the economics of the state and the population health.
well, and the next step I was gonna go is that Vermont was one of the initial states for receiving the match, as I recall. We were at a level where that was the level we were getting, and I don't know how that was determined initially.
Which one's that?
The federal match. And the federal match was determined early on to be relatively low compared to some of these other states like Mississippi.
Mhm.
But that's sort of it doesn't change. So there we are. It's more or
Yeah,
less
so
fixed.
and I'll get into this next week, but the FMAP changes annually. The federal
Right, but
government
it's not gonna
calculates.
go up to the.
Yeah, it goes
70.
up by 0.1 or down by 0.2, but it never jumps by like
Yeah.
3%.
Yeah.
None of the states generally do unless there's a large
Right.
economic piece.
And it's always that we do very well with our health outcomes. I always feel we do really well with our health outcomes with a lower amount of funding, per capita funding. Interesting thought.
So why is this chart showing us up by 56.7?
So what that is, and apologies if it's confusing. I put those little arrows in because it represents whether the United States FMAP increased or decreased from the following year. So Rhode Island's FMAP actually increased, ours increased, Maine's went down from the previous year. So I have another chart which I'll show you next week that shows like sort of the cyclical cycle and the trends. And the relationship it has to recessions and federal other theses. So I'll get more into the weeds on FF. And repetition's good. Some of these slides, you're gonna see the exact same slide again next week, and I'm gonna beat it home. It's not the right word. I'm gonna drive it home to make a point, because we feel like these are telling stories. So I'm gonna tell the story next week, but a little bit different narrative and a little bit more in depth. The other thing I'm gonna talk about next week too, but I'm gonna flag here is this we're currently receiving what's known as an enhanced FMAP, additional 6.2%. And this was part of the Federal Families First Coronavirus Response Act. It was one of the COVID relief things. It was one of the ways that the federal government was providing relief to states was to give us some additional federal match, which means that when they give us more of a higher match, it frees up general fund or costs us less. And so in short, the 6.2% FMAP has translated to roughly $22 million per quarter since the beginning of the pandemic. Now, Ashley will talk a little bit next week about how the federal government's going to be starting to unwind that soon, because what's also tied to that is this thing called maintenance of effort or maintenance of eligibility, MOE. And essentially what it says is we're going to give you this money. However, you also can't change the eligibility requirements. You can't kick people off Medicaid, and you can't do what's known as redetermination. Redetermination is this process by which every year folks on Medicaid have to submit new financial data, their employment status, et cetera, and Medicaid determines whether they continue to be eligible. There's a steady level of what's known as churn. So that's people coming on the system, people coming off the system, and there's a steady churn. Generally, what's been happening is you still continue to have more people coming on than coming off, and so you still have this, this trend of going up, and it's been going up, doing this for years. But when you block one end, people can't come off, and people are coming on. It's doing this currently, and you're going to see that in budget adjustment. You're going to see our caseloads have really gone up, and there's been, I wouldn't say the equivalent level of utilization. Utilization has gone up too. And that's a big piece of what the administration is going to be presenting as part of their budget adjustment correction.
Can I draw a conclusion that the states with the lowest FMAPs are the healthiest, or is that not?
No,
I can't do that, okay.
No.
What those are is those are the states that have,
Good, that's good.
those are the states that have the most money. Like so on the right, the lowest FMAPs, Colorado, California, Connecticut, those are all states that have high per capita income.
Okay.
So it's really tied more to the economics of the state. There's some other nuances in there, but
Are you gonna hit the redetermination expectations?
we'll talk about that next week. There's a plan currently for how they're going to unwind it, but we'll get into a little bit more weeds, and Ashley can talk more about the mechanics of that, and should be able to answer any question you have about that. We'll go more into the weeds on that next week, and help you understand what that's meant and what it will look like going forward, and how, and also just some of the mechanics of how they plan to inform people about that. So they'll tell you all about that.
I noticed that Maine is 10% higher than Vermont. Any particular reason for that?
I couldn't tell you why their per capita, obviously their per capita is probably a little bit lower than ours. There might be other factors, but I couldn't explain specifically.
There's a lot of things you can do with all this data.
Yeah.
Yeah.
And then we're only going to 9:45, right?
Yeah.
I only have like 3 slides and then they're
Let's
fast.
just keep going.
Okay.
I think we'll be fine.
Yeah, we got to the meat
I
of
don't
it.
know whether Andrea is out there or not.
Well, we got to the meat of it. And I can do these
Yeah.
slides in about 1
Yeah,
minute.
let's,
The last piece is just the regulators. So just to give you a sense of who are the various pieces within in government that have some kind of regulatory authority. You have the Department of Financial Regulations. One of the key things that they do is they help make sure that insurance companies are solvent. So they look at the solvency piece. We have the Green Mountain Care Board, who I believe will probably have coming in at some point. They do rate review, so they look at health insurance rates. They do hospital budgets, so they're the ones who help try to control hospital spending. They do certificate of needs. That's when a hospital or medical facility wants to do a large capital investment, more, I think, higher than $1 million or something like that. I don't remember what the threshold is. They have to present a plan, has to have approval. And they're also they're also one of the centerpieces of health reform in Vermont. And they'll come in and talk more about this committee has a lot of jurisdiction over the work of that group. Then you have the Attorney General, which has some fraud. You're gonna hear from the health department. And then Center for Medicare and Medicaid Services, this is our federal partner. That's a term that they just use a lot. Our partner, our federal partner. They're talking about the Center for Medicare and Medicaid Services. Then you just have these other joint commissions, and I don't know a whole lot about them, but I'm just trying to give you a sense of who are the players out there outside of this. Oh, and like I said, we'll talk a little bit about Green Mountain Care Board really quick. Green Mountain Care Board was created as part of Act 48 in 2011. It's a 5-member board. They're appointed by the governor for 6-year terms. So like I mentioned, they regulate health insurance rates, hospital budgets, what's known as an accountable care organization, or ACO. You're going to hear about that very soon. And other major capital expenditures. I did a pretty good job. Pretty up from the start. They also support Vermont's healthcare innovations. You're going to hear about this thing called the all-parent model. They're being Bacchus as well on that. Who's the governor's healthcare reform person. And I do a lot of data analytics. So I've been talking about the expenditure analysis and numbers. They put that out. It's a great document. I'll send it to Alex. I use it a lot, and he'll share it with you guys. And then, yeah, my FPL chart.
Thank you.
That's really good, that chart. I want to take a picture of it.
Yeah. Well, I think if you ask Alex nicely, he can make you all like little pocket-sized ones, and you can stick them in your drawers, or keep them at the bottom of your drawers.
Yeah.
Keep
Look in
it
your
right
drawer.
there. I know, it's hard.
Probably works out.
Having them on your phone though too is nice.
Yeah.
Then you're looking through your photos, and like, where's that damn picture?
True.
So,
Questions for Nolan, and then we'll see if Andrew's out in the hallway. Questions? Thank you. You know what? This is great. And everybody's asking questions that are going to come back to us next week. So this is super.
yeah, this is meant to just give you a start, to give like a high level, like, foundation. So you start hearing these terms like Green Mountain Care Board. Oh yeah, Nolan mentioned that. Global commitment. Oh yeah, Nolan mentioned that. FMAP. Nolan mentioned that.
Yeah.
No, no, no.
It's not